the limited assurance to the finance and transformation piece, given the scale and the volume of the work and the challenges ahead to us. That's not to take anything away from the obvious work that is undertaking at the moment, but I think just picking up on Muriel's comment, I think when we see that being translated into delivery and we can actually be ticking things off rather than planning for, we should be able to move forward. So if everyone's happy, I think we record in the minute, Stephen, the finance and the transformation piece, the committee are taking limited assurance. Thank you very much, everyone. We will now move on, I think, hopefully to a more discussions on actually delivery and moving things forward. And I'll ask Arlene to introduce and take us through her Learning Disability Services Assurance Report. Thank you, Arlene.
Thank you. And kind of following on from Pam's difficulties around about using the PowerPoint, I've asked Stephen to share my presentation, and I only have one slide, so hopefully then it won't move. So it's more of a kind of something to look at rather than me while we're talking through the paper. So I'm going to make an assumption that people have read the paper, and I'll pull out what the main points are and add some additional information into that, and then we can have the discussion if anybody would like to. So within Highland, we have approximately 1,034 people with a learning disability who are known to health and social care services within the Highland Health and Social Care Partnership area. That's in line with the population data, which would take us to about 1,200. And so not everybody with a learning disability will be known to our services or receiving services as such. And the way that we record a learning disability from GP practices perspective is quite difficult at the moment, and there is ongoing work with Scottish Government about how we record that data more effectively going forward. Learning disability services are delivered both within health teams and within social care teams. And if you go back and thinking about when Elaine presented the month 2 report and mentioned the mental health budget, the learning disability adult social care spend is not attributed in mental health, it's attributed within the partnership rather than within mental health. So the adult social care spend that you see on that line when Elaine presented it is the mental health social care spend, not the learning disability social care spend, which I think again also highlights the complexity of the system that we're working in. And I think you reflected on that earlier today about how much information and how much work is going on within a very complex system that we're working in, and the learning disability services are no different. And we have the responsibility and accountability for the health services to people with a learning disability. The specialist health services sits very firmly within mental health services. For example, if anybody with a learning disability is requiring general practice support or in acute health care, that would be the same as anybody else. It's the specialist element of it that sits within my responsibility and accountability, and the responsibility and the accountability for the delivery of the adult social care is shared between myself, between the adult social care leadership team, and between the communities, because it generally is the social workers in district teams who commission the support for individuals with learning disability. So a complicated landscape to pull together from a strategic aim and from how we ensure that individuals are receiving the best care and support that they can do. We currently spend approximately, it's just under, for the projected spend for this year, is just under 34 million across 20 different providers. And you can see on the pie chart there that's how it's divided up. And actually, that's quite reasonable. We've got a big chunk of our support is delivered by Richmond Fellowship Scotland and by Key. It says Key Housing Association. They dropped the Housing Association. They're just Key now. And we have a number of other smaller providers, some who provide very specifically. Thera are very clear about who they provide support to and who they don't provide. Other are, for example, Gold, who started off Life in Highland as an agency and who families have said that they were appreciative of the care and the quality of the care that the workers provided, and so therefore have moved into getting a support contract with NHS Highland, and so therefore deliver care and support through the support contract. I think that the market share is quite well balanced in that we've got a balance of big providers and small providers, which shares the risk out between them. But we are always looking to expand our provider base, and we're currently going through due diligence with a new provider in Highland, again, who started off life as an agency within Highland and are looking to have a support contract and working through that, which is also helpful when we start to talk about agency spend. If we can move the work away from agency provision into substantive workforces, if you like, through organisations who also provide agency work, then from a staffing perspective, what we're seeing is that the workers themselves can still do some of the variety of work that they enjoy as an agency worker, but we get more stability through the support provision and therefore more efficiencies through that element. So it's a good way to shift from the agency work into the substantive support contracts. The risks that are currently experienced by the support sector are the same risks that we have described over many months that they're experienced in the care at home sector, which is around about recruitment and retention, and that would be the biggest risks that they come back to us with about their concerns. We have been doing a lot of work around about our buildings-based day services over the last few years, and that continues to provide support to the individuals with the highest needs or the most complex needs, and has got a focus on employment opportunities. And the picture that you can see there is from the new shop in the Invergordon High Street that the guys from the Isabel Rhine Centre make craft activities or plants, as you can see there. They grow them in the Isabel Rhine Centre and then they sell them in the shop. And that's exactly the model that we want to be encouraging and enabling, is for people to be doing more activities that are related to employment. And I think it goes back to some of the elements of that will be as we become more advanced in that is around about the workforce, because if some people could be receiving their support through supported employment rather than through paid support, therefore we're requiring less paid support workers. So the elements of us as a statutory organisation, if you like, helping create employment opportunities will show benefits in the support sector and within the workforce going forward in time. And that's always been one of our strategic aims. If people are down in Fort William, they may have also gone to the Vintage Cafe in Fort William High Street that's run by the guys in Montrose Centre, and it's fabulous. You get a cracking scone if you head on down there. Health checks, we have, and I think we discussed at last year's paper around about the Scottish Government DL letter saying that we needed to now be delivering health checks for people, all people with a learning disability across Highland. We've now agreed the model for that, and we've employed an advanced nurse practitioner who started work in February and is now out and about delivering health checks. We didn't have any figures at the time when I checked and I wrote the paper, but we will have for next year. We won't, like the rest of Scotland, we haven't got enough money from the Scottish Government to deliver a health check to every person, which is what they had asked us to do. Every health board is feeding back that without the actual resource, we can't provide that without having an impact on other services. But what we are doing is we're prioritising those individuals with the highest health need in order to do the health check first, and then we'll work our way through that. There are ongoing conversations with the Scottish Government that service may evolve and the ask may evolve as they start to work up what some of the different tools are that could be measured or could be used to help measure people's health, and how we could do that perhaps more remotely, for example, rather than necessarily in person, which is what the ask is at the moment. The next part on the paper focuses in on complex needs, and the last paper we delivered to the Health and Social Care Partnership Committee was around about and we focused in on those individuals with the most complex needs and how we were delivering their support. And we gave you quite a lot of detail around about the new housing development in Muiraford and the significant recruitment challenges that they had. There is still only one person who has moved in. I mean, he's absolutely thriving and loving living in Muiraford, and his family being able to. There was a man who came back from an out-of-area placement who had been in hospitals out of Scotland for 16 years, and he's absolutely thoroughly enjoying being closer to his family, and his dad visits with his dog and such, like all of the things and all the reasons why we do all this work often is shown out in there. However, there is only one person living in what is housing for 6 individuals. I did have a meeting earlier on in this week, and it does appear that key recruitment has just in the last couple of weeks taken an proving position. And we've also done a piece of work where we're bringing together 2 clusters and we're moving individual people around about a bit in order to try to make a bit more sustainability. And with a fair wind, we're hopeful that 5 out of 6 people will have moved in by autumn, which is I'd be delighted about if we can actually achieve that. The plans, and I think that goes back to what Pam was describing earlier around about the Aslo social care plans, which are detailed. And I can, if people would like more detail about what sits under those headings, they're kind of fairly broad headings, but there are plans that are much more concise, which sit underneath each of those. For example, we were talking earlier about night support and telecare. We have a successful waking night responder service in Inverness. We are currently in the process of doing a tender exercise, or about to do a tender exercise for a similar model in Nairn. So we're looking at lots of different things, and all those individual parts sit under each of those headings, which I can give more detail to if anybody would like. I think that's probably all I would like to say at the moment in relation to the report, but if anybody has any questions, very happy to answer anything or go into more detail.
Thank you very much indeed, Arlene. It's nice to just get a bit more on the topics covered in the report, which I found very, very helpful. And I think you're absolutely right. Is building on the previous reports, so rather than looking at it as a standalone report. So I think that's incredibly helpful. I'll throw it open for some questions and discussions, as I'm sure colleagues will have some comments and questions they want to pick up. Kay.
No, it's great. It's great that somebody's moved into Muir of Orden and enjoying it, and that's really good. It's just a shame that there's only the one person, but hopefully there will be more people soon. As far as the employability thing is, I mean, we've been helping people when I worked at the Isabel Ryan Centre for the last at least 20, if not 30 years, they've been helping people into employment. So it's not a new thing. But if you look at the demographic that is employable at this stage, the older set of people, and it's that piece of work in between, because we used to get people from school and we would do the work. It might take 10 years to get somebody to the stage where they were able to do some of the activities that would be employable related, intensive work around group work, about social interaction and things like that. And so in a future model, how is that going to happen? So you've got these people who are doing the employmentability thing now, the older ones that have had work for the last, intensive work, in groups and one thing and another to get them to this stage. How will that be done in the future?
So I think you're right. The younger adults, if you want to kind of those individuals that are leaving school, are choosing not to use building-based day services and working with their families, and that's a lot of the feedback is that actually the families' aspirations are different than those what might be the traditional models of buildings-based day services. There are organisations within Highland, Enable Works is in Highland, who work with younger people. Canterbury College work with younger people around about finding employment for them. And there's a piece of work that the Scottish Government are kicking off around about employability that Highland are going to participate in, and we're just not quite sure what that means going forward, which I believe the Scottish Government are about to put more money into ensuring that people with a disability are offered opportunities within employment, and we'll kind of figure out where our services mesh into that.
So it wasn't so much it was how to get them to that stage. Does that mix? It's when a lot of people leave school, they still need that time to mature and gain skills in order to be able to think about employability, and it's how to get, it's that middle bit, obviously there's people who are able, in very short time to get those skills and that, but sometimes it takes 10 years, sometimes it takes 15 years, and sometimes it's just that development stage that's what I was wondering about.
Yeah, and I think we wouldn't be considering individuals with a learning disability any different from anybody else in that, those of us who've got teenage children at home who are making their minds up about whether they should go do this or not do that or what have you. We do have college placements that are accessible to people with a learning disability. Like I say, we've got other third sector organisations that will work with people while they make up their mind how they want to spend the rest of their days. And I think we have a generation of young people who no longer want to do the same thing for the rest of their days. And so we are responding to that on a very individualised way.
Thank you, Arlene. Joanne.
Yeah, thanks, Jerry. Arlene, I've got a couple of things. You have kind of covered it, but just so that I'm clear. The first one is around the health checks. I know that you've said that you're kind of having to limit the service, but I was wondering about how many were eligible out of the number of known to the service will be seen and what the projected shortfall is. And I know that you said that you didn't quite have stats at the moment, but I would be interested in that moving forward. And around that, was the geographical location taken into account when we were allocated the one full-time post? And I've just wondered if you could comment on equitability for service in terms of people and geography, if we know it's restricted and it's one person in post. And my other question is just around the cluster homes. I just wondered how the model will be evaluated and how we will know if it's working. I know that you've had a lot of problems with recruitment, but at what point is the evaluation being done, and when will we know, whether that's a model that will be the one that we're working towards for the future, or are there other things out there? Thank you.
So in relation to the health checks, the Scottish Government funding was allocated through the NRAC formula. So that's probably a bigger conversation around about that. I don't believe there was any different way of divvying up the pot of money that they had for Scotland to Highland than they would usually do, and that I believe was there. There is a bit more money than just the one person that we've employed, and we are the part of the model is linking with the community learning disability nurse teams in each of the localities. So if you're already known to a community learning disability nurse, it's likely that the community learning disability nurse will do the majority of your health check, and then the specialist elements will be topped up by the advanced nurse practitioner from there. So but what we can't do is take the learning disability nurses to only be doing health checks. They have other more specialist roles that they need to be doing. So there's a bit of a balance in that, and that is it's an evolving model. That's the intention. We're kind of wanting to see how that goes, but we will have come sort of probably. Yeah, somewhere in the autumn, we'll have the figures of how many has she been able to do. She's been in a start-up phase at this point in time, so she wasn't quite sure what her projections were. But we can get that to you, Joanne. That would be easy enough to do. In relation to the cluster housing models is in a very well researched model, and has research and evidence to say that it is the most efficient way of delivering individualised care to people from a housing perspective in community settings. We are having conversations about is it actually about location? It's not that the model is wrong, it's about the location, and that have the provider been unable to recruit because of its location in Muir of Ord as opposed to other clusters. We have there are about 24 different clusters across Highland. It's sitting in communities that people will be kind of probably completely unaware of, that are happily supporting, between 3 and 6 individual people in their own houses, and there isn't the same issues around about recruitment. Muir of Ord seems to have been particularly, but more than particularly, it's been very, very difficult in there, and we're trying to kind of work out how do we unpick, is it Muir of Ord or is it the current time? And we're not sure how to do that. So I think the focus has been on can we get people in, let's put all of our energies into the recruitment and getting people moved in, and then we will do that element of it around the evaluation, but it certainly is in our mind to do.
Are you okay there, Joanne? Does that answer your questions? Thank you very much. Neil, welcome.
Thank you. It's just a very quick comment, and it's with regard to the with regards to health checks and limited resource. I would have thought that some of your LD clients will have long-term conditions already anyway, and how much of the health check would already be covered with their, hopefully, annual routine, say, diabetic review or cardiovascular review in their general practices. I can't think off the top of my head how many we have here, but I'm just wondering how much of the health review would be covered by that, and therefore you may be able to target your resource a little more, because some of your folk may already be getting those checks, hopefully on an annual basis.
Yeah, and I think it's the hopefully element of it, that we know it's not consistent across Highland, and so when you're setting up a service and when you're looking at a model, you're kind of looking at what can be done elsewhere. So there are pockets, and there's pockets of fabulous practice where actually the GP is probably pretty much going to do the majority of the health check with a bit of support from the community learning disability nurse, but it's not the model that we were able to roll out from that angle. And there's been different models across Scotland. In some areas of Scotland that GPs are and the funding is sufficient. I don't know how, but the funding is sufficient to enable GPs to do that. That wasn't possible within Highland. That was the model we looked at. But yeah, there's lots of really good practice where actually GPs are working very pragmatically with us, exactly as you say, Neil, that for some people, lots of checks already happen, and then for other people that it doesn't. Yep.
And Kay, I've got you again, yeah.
Yeah, I was just wanting to come in about the cluster housing thing. I think possibly part of the historically people who live in the community didn't have very complex needs, and I think perhaps that may be the part of the problem of the recruitment, because obviously a lot of staff who are paid at that level don't have the confidence and experience, and those staff with the confidence and experience are at a higher level than would be supporting in a housing setting. Would you think that one?
I don't think that fully explains it. I was kind of, on my own personal experience, I was employed in Highland as the occupational therapist in the resettlement team when we closed Craigfadrick, and that was probably about 30 years ago. Maybe not quite as long as that, surely not. And that time we were moving individuals that were deemed to be complex into their own homes in the community settings. And then again in 2000, when coming the same as you came out, which said that nobody's home would be a hospital, and therefore those individuals who were deemed too complex to move out were then started to move out. So I think for the last 20 years, actually, we have been slowly doing that work. We've been doing it quietly, and actually I think that's a sign of success. If people don't know that people with very complex needs are being supported in a community setting, then actually all of the professionals have done their job, and that people are then integrating into the communities without it standing out or being kind of front page news, if you like. But there has been a shift. I would agree with that there has been a shift towards from people being in more residential or institutional settings into living in their own home. And I think the models of support for workers around about individual tenancies, there's been more of an increase in individual tenancies in the last maybe the last 10 years, and that's where workers say that they have less confidence because they don't have people around them who could perhaps support them within in a crisis. And it's at that I think there has been a change, and we've done a piece of work and we talk about that in the paper around about the isolated tendencies of bringing people back closer together, because that feels like it's going to be more sustainable. That's a long-term piece of work, because that will involve the council building some new clusters, and people have a right as a tenant. They may choose not to go move into their new home next door to other individuals, and so that would be a challenge as part of to achieve that.
As far as the people who moved out of Craigfadrick, as far as I can remember, there was quite a few of them moved into a group home, and then when that closed, they moved into residential care altogether. So I off the top of my head, I can't think of anybody who actually lived in. There are a few that moved to Key, but they haven't. I would say needs, but no complex needs. if that's they're not complex needs, as in sort of needing 1-to-1 or 2-to-1 all the time. So it's a different group of people, or It's not the complex needs that you suppose these people have. Does that make, am I making sense?
I think you are making sense, but maybe you maybe wouldn't have necessarily known all of the full picture of the individuals that were going there from that perspective. It would have been kept on the basis of an individual, so it would have been those workers at the time that were working rather than within a small locality. It was across the entirety of Highland that people moved.
Thank you, Arlene.
Yeah,
I've got
may I
Simon, I
intervene
think I
here?
saw your hand pop up there, yeah?
Yeah, apologies, Cara, but I do need to come in here. I'm becoming slightly concerned that with the numbers of people we're talking about, the locations, etc., we're getting into personal identifiable information, and I think it'd be helpful if we drew back from this conversation at this point, please.
Thank you, Simon. I was about to make the very same comment myself in terms of it was getting away. It was I had got no idea at all, but of course I've not got the knowledge. So thank you, Simon. I totally agree with you. I'll maybe move on to Cara.
Hi, Arlene. Thanks for the report. I was just interested in terms of the information around the dynamic support register. And as I understand it, I think that will inform sort of future commissioning intent. And I was just wondering if we'll maybe see that coming out in future reports and where you see that fitting. And the other question I have was just about, you mentioned about that engagement with the Highland Council and NHS Highland. We don't have houses ourselves, and we know we're in terms of our partners and housing associations. And I'm just wondering in terms of what you see are some of those risks potentially, noting some of the challenges around housing and access to housing and thinking about those models in the future.
Yeah, lots of big questions in there, Tara. Dynamic support register, yep, so we've kind of identified that there are 58 people who are currently on the dynamic support register. It is actually an excellent tool, and I'll say it's an excellent tool because we were involved in the development of it from a national perspective. So we're slightly biased, but it does allow us to have to enable teams to identify which individuals should be prioritised when there's not enough resource for everybody to do everything that they would like to do. Then this helps us to kind of have those conversations with team about that, and it is already feeding into some of the strategic discussions about what we're seeing as the themes. It's easier to see the themes because everybody's recorded on the dynamic support register than perhaps in our Highland locality when it would have been sitting within districts perhaps and not necessarily coming together. So we're already starting to see that pooling together. We haven't quite got to the kind of finesse of being able to say exactly what it is we're now going to do as a result of that, but we are pulling those conversations into it, and they will come into the plans that were discussed earlier around about the adult social care. Well, they will all that information will be the kind of data that supports those decision making. The concerns around about housing and the risks about housing and working with our housing partners, kind of as you're aware, it's ongoing conversations, and Pam mentioned this earlier in her report, was about the ongoing conversations with housing about what is it that's required and what's available. And it often feels like it's a new cluster is a bit of a perfect storm, that we have said that this is what we require, that the land comes up at just the right time, the grant funding to build the houses comes up at just the right time, and we've always managed to do that without having to put any capital funding in to the council around about housing. As you say, NHS Highland don't own houses and should not own houses. We are not a landlord. People should, and I think that's a really, really important principle that we work with, that people with a learning disability have a right to their own house, and that should be the same way as everybody else has access to housing, and therefore gives access to housing benefit. So ongoing work with the council around doing that. There's no plans in the pipeline. There is no agreement at this point in time for a new cluster. We are exploring what the options might be for new clusters.
Thank you very much, Arlene. I think that's a good point to draw this to a close, that people suffering from a health need are not deprived of access to any other services which any other individual is fully entitled to. So thank you very much, Arlene, there for the report and actually the presentation and taking all those many quite challenging questions. So committee, we're asked to note the report and recommendations and accept moderate assurance. Are we content to do so? Yep, I'm seeing nods and thumbs up, so thank you very much indeed, Arlene. We'll move on to primary care services update. I think Jill has joined us. Apologies, Jill. I think we're probably way behind the timetable on the agenda, so apologies for keeping you waiting. But I'll hand over to yourself. Thank you.
Thanks, Jerry. I am assuming everybody's read the report. It's quite a comprehensive update this time. I'll just pick out some headlines, and then if people want to ask me questions, I'm happy to field the answers, no problem. So starting off, we've just given you an update on community optometry and work that's ongoing around the community glaucoma service. Really good that we've got people trained and ready to go. So we're looking at a bit of development work between ourselves and the community, and also with our acute colleagues in relation to the IT equipment to get the pathway up and running. Some other work as well around the stroke pathway, and we've also started our governance meetings, governance visits, across Argyll and Bute and North Highland, and the team are now back on a rolling 3-year programme, which is great, and also some developments around foundation training, which is offered by NES as well. Dental, there's a bit of an update there in terms of some access, a bit of a mixed picture. So we have got 3 practices that are actually offering dental registrations on the NHS. However, we do have practice closure out in Kyle on the west coast. So a bit of a moving picture in relation to practices opening up and accepting registrations, and whilst others still struggling to recruit in some of our remote and rural areas. The SDAI grant assistance scheme has been welcomed in Highland, and you'll see that there is one application that is in taking new registrations, which has been part of that scheme. Bit about the payment reform, so the new contract for dentists. It's early days, but it seems to be welcomed in the main by our dental providers. Still having some issues in relation to recruitment within our PDS service. Contributing factor is a shortage of dentists, and they are looking at skill mix and different options there. Oral health improvement, obviously, those initiatives still continue and have continued as much as possible through COVID as well. Moving on to the board managed GP practices. So we've just updated and refreshed the list. There's been a couple of changes since we gave a comprehensive list to committee. There's also been a couple of mergers that are listed there. So the practices in Caithness that are board managed have been merged into one, and also down on the Ardnamurchan Peninsula we've merged Acharical and Lochalan as a result of the GP in Lochalan retiring. That was a single-handed GP. GP recruitment remains challenging. We do have vacancies across remote and rural, and we have got a reliance on locum. I think Elaine's covered some of the locum expenditure within her report. However, there is a really good turnaround story in relation to Alness and Invergordon. So over the past 18 months, we started when the board took over the practice. There was no GPs, and we are just under a full-time vacancy remaining within the practice, but the team have done a fantastic job in terms of supporting the staff and recruiting into those key jobs, and there's a development plan in place, and obviously look forward to working with the team to actually move them forward on a much better footing than where they were 18 months ago. There's a quality improvement project that we're looking at. It's around asthma care, and we've got 2 pilot sites, Alness, Invergordon and Mallaig, and we'll report back on that. The view is that we'll take that project and we'll run it across the other 2C practices. Lease assignations, so we've got a couple of ongoing discussions at the moment and several lease negotiations, and that's part of our new contract arrangement and some others in place. We've got some dedicated support looking at that. Development in Inverness in relation to Culloden Medical, Culloden Surgery. These 2 practices are co-located in premises that are owned by the GPs. They've been struggling for the last couple of years. We've been working with them really closely to look at alternatives for premises and accommodation, and unfortunately they've now made an application to close their list just due to the constraints. So we will continue to work with them on an ongoing basis to review the number of patients registered, and also thinking about all of the other practices that do have open lists across the city as well. Local enhanced services discussions are ongoing and progressing with the Highland Local Medical Committee, and looking for a favourable outcome within the next couple of weeks. So that's good. We've given you some information there around the primary care improvement plan and the different elements of that in terms of the work streams. So pharmacotherapy, first contact physio, a great kind of scheme that's been developed by the team and implemented by the team, which is FEO Access, which is an online service which is proving to be really welcomed and well used by patients that are using it. Again, another really good story around our community link workers. We've had some funding allocated through PKIP to extend the programme across all practices in North Highland. It was originally just 29. So some really good results coming out of that programme of work as well, which is really, really good to see. And that's commissioned obviously through the third sector. Primary care mental health, a few issues in terms of recruitment, but those teams are actually embedding now within the districts and within the localities. VTP, I'm sure is in Chief Officer's report. There's obviously been the Public Health Scotland peer review, and there is a piece of work through the Vaccination Improvement Programme that we're looking to pick up from a primary care perspective. And in relation to CTAC, we have a rural options appraisal, which we had an initial discussion with Scottish Government way back in May. We're looking to conclude some further work on that before we resubmit to the GMS Oversight Group, which is a group between Scottish Government and SGPC. We're continuing to pay transitional arrangements. So, Jerry, that's just a huge whistle-stop tour of what's within the report, and I'm happy to take any questions.
No, thank you very much indeed, Jill. It was a comprehensive report in terms of the range of activities going on. I'll throw it open to questions, and perhaps maybe I'll maybe just steal a march on everyone while they gather their thoughts. I had picked up on in the report the Culloden practice requesting to close their list. Can you just inform the committee, for those who don't know? So what happens to a person who cannot get onto that list? Where do they access primary care services?
Yeah, we've got a role within that, Jerry. So there's two levels that we look at. So it's a bit of a dynamic process with a registered list. So you've always got people who are moving out of area and coming off a list, and then obviously new people looking to come on. So what happens now is that the practices have set the ceiling. So in terms of the maximum they can achieve, and what we do is we have monthly meetings with them to look at the activity. But basically anybody who is not able to access or get registration there, we're signposting them to other practices, and if need be they can come to us direct as a board, and what we do is we then allocate them to a practice or give them the choice of practices that are open. So we do generally work very closely with the practices in this situation, and also where we've got family members or new children born, or sort of circumstances that are pragmatic, we incorporate them within the practice list. So it's a bit of a dynamic process. It is a bit ongoing, but it does attract a bit of scrutiny from Scottish Government when we declare we've got closed lists.
Yeah. Okay, thank you very much, Jill. I'll throw open any questions from anyone. I'm not seeing any, Jill. You've obviously covered it very well there, and thank you very much indeed for that. So we've been asked to note the report and accept moderate assurance. Are we content to do so? I'm seeing nods and thumbs up. Jill, thank you very much indeed for your report and your update to committee. Thank you. Bye-bye. We'll move on now to adult support and protection. I'm not 100% sure who's providing this update to us. I don't have a name on my agenda. Apologies, folks.
Apologies, it should be Ian Thompson.
Right. Thank you very much, Stephen. Ian.
He was here just a moment ago. He might be having access issues.
I can see. Yes, his microphone keeps going on and off. Simon, I'll bring your good self in to kick us off. Simon, you're on mute.
Right, I'm not now, I promise. If Ian's not able to join, I'll steal his thunder if that helps, and I'll allow the meeting to keep going. So firstly, apologies. Ian has done a huge amount of work around this, so I really don't want to be taking credit for the work that he and Ruth and others have been undertaking. The report you've got in front of you essentially is a comprehensive report describing the context, duties, processes, etc. I would commend to members, not that we discuss this, but that all members make themselves familiar with it. And the reason why I would do that is because in terms of social work and also adult social care, but also in terms of other community health services, we need to just remember that in a world where we are often talking about issues such as delayed hospital discharge, etc., our number one priority is the protection and welfare of people that we work with. And sometimes that gets a little bit lost. So apropos the previous conversation that was going on with regard to, for example, staffing levels, etc., we tend to talk about that in terms of carers. And I would just ask members to read through the description that you've got there of what goes into adult support and protection. Then think about the increasing number of incidents we're dealing with, particularly around large-scale investigations in care homes, etc. And think about I was going to say the burden of work, but it's the amount of work, the amount of reporting, and the impact of getting it wrong. So I think it's really important that members of the committee note that, if that's possible. There's reference to the inspection that was undertaken. So we were previously inspected some 5 years ago, and we've had a subsequent inspection. I think it's safe for us to say that we approached the inspection on the basis that this was a learning journey and a development journey that we'd been on since the first inspection. We realised we had a lot to do, and the report before you describes that the view of the inspectors was that whilst there were areas for improvement, there was a level of robustness and assurance could be taken from where we were at. Please do not think we are complacent about it. Nobody should ever be complacent around protective issues. However, I think it is really positive that we received that. So the findings are in page 9, and then subsequently in page 10, you'll find that there's a series of recommendations and areas of work that we're taking forward. Just to be aware, we're taking those forward through the vehicle of the Adult Support and Protection Committee, and we're doing it across health and social care. So for the purposes of this committee, I would make a particular observation and say it's been particularly gratifying and positive to see the extent to which health services have embraced this, because although people think of it sometimes as a kind of social worky thing, it's actually a total system thing. So the report is there for you. I don't want to add any more than that, if I may, but I would commend to members, I really would commend, if you get the chance, read it to get a really clear understanding of what adult support and protection is really about. Thank you very much, Chair. I hope that was okay, and by the way, that's me freestyling it for you.
Ian, I don't know if you want to come in and say anything, but I would before you do, I would just say I would absolutely echo Simon's comments. I found it an excellent report, and again, just for committee's awareness, I'm sure everyone will remember, we're not an assurance committee for adult support and protection, as Simon points out. It goes up through the Adult Support and Protection Committee, but it's really important to our work that we understand what is going on here, and that comes across very clearly in the report. So before I hand over to Anne, Ian, is there anything you wanted to add to Simon's beautifully sculpted freestyling? No, we're not hearing you, Ian. Anne, I'll let you come in.
Okay, so I think it is a really important report for us to be aware of the work, as Simon has mentioned, and I think we should record our thanks for the considerable improvement activity that has gone on between these inspections, because they clearly do show a considerable improvement, and so well done to everybody that's been involved in that. I know there's been a lot of hard work over many months. I just wanted to ask a specific for assurance on something. I'm aware that there was a report of an independent review of a particular case published recently, and I just wondered if the action plan against the inspection covers off the kind of issues that were raised in that review, or if that's being dealt with in some other way. Thanks.
I'm
Are
happy
you
to
able
answer
to come
that,
in there,
but
Ian?
I don't know. I'm trying to speak, but
We can hear you now.
You're hearing me now. No, I think that we would take action separately and from any independent reports. So we have had a number of learning reviews ongoing. Some of them are producing their findings now, and we would add those to our improvement action plan, separate to those in the report. So that's not the totality of our improvement actions. That was the one that's as the appendix is there in relation to the report. But if there are particular issues arising from a learning review, we will deal with those in addition to the action plan.
Thank you very much, Ian. That's helpful. Excuse me. So, taking Simon's and Ian's comments on board, we've been asked to note this report, which I think is and take substantial assurance. And I think we're taking substantial assurance on the work that is ongoing. But it's, I say, we're beholden here to the Adult Support Protection Committee, who will actually oversee the work in the Chief Officers Group. But I think I would echo again Anne's comment. It's you can see the quality of the work which is ongoing here. So, Ian, thank you very much indeed for a very comprehensive report. And I think if anyone did want any more information, okay, if they just contact you directly, Ian, just to get some more information. So, thank you very much indeed to Ian and Simon. We will move on to the Chief Officer's report, which colleagues will notice has got quite a lot in it. This committee cycle, so Pam's going to take us through the report, probably in a bit more detail than we normally go through. So thank you very much, Pam.
Okay, thanks, Jerry. So I'm just starting off with my report to say that the fire upgrade work for the Ross Memorial Hospital at Dingwall has been agreed, and all the processes are in place. So it's taken some time to get that over the line, but part of that work was as well to articulate, the future model for Ross Memorial in terms of the reconfiguration and some links with hospital at home and same-day diagnostics and all sorts of other plans and processes. And just to mention that there will be a process to rename the new ward, so that will be coming out for voting and/or whatever the process is. I'm not sure, but that's a really good story to start off with, a good update to start off with, because I know there's been a lot of concerns raised in the committee about the time it's taken to take the decision and for NHS Highland to agree to take the project forward. So that's positive news. So I wanted to focus in line with a lot of the transformation discussion we've had and some of the issues I've referenced earlier. There is a national focus on people in delay. So there has been stood up a national collaborative response and assurance group. The acronym is CRAG, another acronym for us, and that's being jointly chaired by the Cabinet Secretary for NHS Recovery and Health and COSLA as well. So they are taking a very focused deep dive into each integration authority to make sure that we are able to demonstrate the impact into reducing people in delay. So we are tasked to reduce for each integration authority, we are tasked to reduce to 34.6 delays per 100,000 of the population, and of course we're at 100 delays per 100,000 of the population, and we're at the top of the statistical chart in terms of Highland having the most people in delay. So that has been a particular challenge for us. The meeting is weekly, it's very fast paced. The national teams seek assurance. So yesterday there was a specific focus on Highland, where I went through a number of approaches that we had, also through a presentation. And previously I had met with Miss Todd in her role of the Minister for Social Care and Mental Wellbeing, along with Highland Council colleagues, and Simon as well, just to give her assurance around what we're doing around people in delay, how we're reducing length of stay in our hospital, and all of the work streams that we have around that. So she has herself stood up monthly meetings to have with her, and that's in addition to the bi-monthly meetings that we have with Scottish Government around our urgent and unscheduled care programme. So I'll just pause there, or Jerry, do you want me to go on a bit?
I would just carry on, Pam, and we'll collect questions at the end.
So within the paper then, there's a specific delayed discharge and reduced length of stay action plan as part of a suite of plans that are progressed under urgent and unscheduled care programme charter. And I put them into the documents. I don't normally add this amount of detail into my Chief Officer's report, but this is important just so that everybody can be cited and take assurance from the specific action we're taking to reduce people in delay. So we've got an urgent and unscheduled care charter. So in line with the charter process that Rhiannon outlined earlier. A key one for community services is how we develop urgent care responses, whether that's around hospital at home development, whether it's about preventing people coming towards hospitals and to the acute front door. So making sure that we have the flow absolutely right, and that we work in prevention, we work in frailty, we address and we anticipate winter planning, although we are experiencing all year planning just because of our population and remote and rural and workforce challenges. We continually have our contingency plan stood up and our workforce deployed through our CRT, etc., and a number of other responses, and also specific interventions around our mental health pathway, so that we don't have people in delay within our mental health service. We do have a number of deliverables and targets within the charter. I would just say that the delayed discharge, just on the bottom right-hand corner there, to reduce 60 by Q4 for 24-25, that was prior to the Cabinet Secretary in COSLA standing up the CRAG group and for us to give weekly surveillance. So the challenge of reducing delayed discharges is very, very challenging for us. The biggest challenge being the destination that people can go to, i.e. they're not able to return home quickly because we have capacity and delivery issues in care at home from a workforce availability perspective, and also in terms of the independent care home sector. The loss of just under 200 beds in the last 2 years correlates directly with the amount of people we have in delay. So a challenging set of sector complexity and sustainability challenges that underpin that. However, we do have focused plans around urgent and unscheduled care. So again, using our driver diagram approach that Rhiannon outlined earlier in terms of the process. So the vision is that we respond to our population when they've got an urgent health problem, making sure that people with life-threatening emergency needs are seen in A&E, and that people have an urgent care response in the community and that they don't make their way into accident emergency departments. particularly in and around Raigmore, where we've got significant population there and who make significant demands on A&E in terms of walk-in. Another one of our challenges, wider challenges, is the length of time that people stay on the phone to NHS 24. So we need to work with wider partners, because when people are waiting, for a callback or waiting in a phone line for NHS 24, quite often, families are very concerned, and they often, dial 999 to get a response when they're concerned about a loved one. So we need to make sure that we work wider than just in NHS Highland, that we work with our national partners, that we work with Scottish Ambulance Service in terms of call before you can convey, and that we develop all sorts of urgent care models with partners. So you can see the things that we need to ensure is about reducing demand on emergency departments and making sure that we've got effective flow through the hospital and transition into community support for people, when they leave hospital. So we've got a number of actions in the blue column. So you'll see a number of aspects that I've just articulated, and then moving on to the orange column, very specific and detailed pieces of work and work streams across our acute and community system, and working with our sector partners. So I think I'll stop there just before I go on to the audit report, Jerry, if that's okay, if I can take some questions around urgent and unscheduled care and people in delay.
Questions, comments for Pam from anyone?
No. Okay. Shall I carry on? Oh,
Anne. No, Anne.
Sorry, Pam, could you just clarify? You mentioned what the target is. 60 by Q4 24-25. Well, two things, I suppose. You mentioned that what's the ask is of this latest initiative from Scottish Government is much lower than that. I can't see achieving the Scottish Government target as at all realistic in the space of a year. So I wanted to ask, are we sticking to that original target? And also, have we got interim targets for Q1, Q2, Q3, so that we can see, track and adjust before Q4? Thanks.
So each integration authority is being visited in person. So we've got the Permanent Secretary coming to Highland on the 17th of July. That's an opportunity to have that discussion, to show trajectory in terms of where our baseline is and the interventions that we can provide. And also, we need to have that discussion about how challenging it's going to be for us to reduce people in delay to the number that's been proposed by the Cabinet Secretary and COSLA. So we just need to have a discussion about that. But one thing we need to do is set out a planned trajectory using our baseline data, and Lorraine and I are just working on that at the moment in preparation for that meeting. So what I've got in the charter was set out last year in terms of our trajectory from our own baseline, and the Scottish Government and COSLA have come in with a new direction, asking us to achieve a very, very challenging trajectory, against, the remote and rural provision, the long-standing workforce issues we've had, and that are still continuing in the challenging, recruitment position that we're in, and just lack of destinations for people, the sustainability of the care home sector and care at home. We will have an opportunity to talk to the Minister about all of those things again, and again, seek much more inputs into remote and rural health and care from a national perspective.
So does that mean, Pam, that you and I'll say you, it may not be you on your own, we will have the opportunity to have a discussion with the Minister the Minister may or may not accept our discussion points, but we'll have the opportunity to say we don't think we can do X, we think our trajectory could be Y. But at least we will have the opportunity to do that.
I'm not sure that we can negotiate the trajectory. What did happen though was the COSLA and the Scottish Government wrote to us around the 17th of June. They wrote to us and to the Highland Council jointly as part of the collaborative response and assurance group, this CRAN group, and they asked us to give some feedback around what areas are challenging for us in Highland. So we certainly fed back using some information that we'd already used as part of the COHI, feedback and response that we'd already done, so that we were given a consistent message around some of the strategic challenges. So not just the market, not just the collapse of the independent care home sector, the wider population challenges, the wider issues about sustaining remote and rural communities, and some of the issues and impacts around housing access for support. So we were giving them a frame on the more strategic issues rather than the minutiae of how we actually deliver, discharge without delay processes or discharge processes on a daily basis within our operational unit. So it was really helpful to set that out. And we've not had any feedback or a response from them in terms of sending that letter, but that letter was sent jointly by myself and Fiona Duncan, the Executive Chief Officer and Chief Social Work Officer in the Highland Council.
Okay, thank you, Pam. I'm not seeing any other hands, Pam, so I think we'll just carry on. I'm conscious we're rapidly closing in on 4 o'clock.
Oh gosh, okay, I'll be quick. The next one is really important in terms of, being clear about how we are delivering within our organisation and how assured we are about the systems and processes that we have that I've articulated for urgent care and unscheduled care and supporting people in delay across our system. So an internal audit was undertaken, and to be clear, the audit findings were really disappointing. They found that there was confusion across staff teams about their role in discharge planning and really a lack of standard work or SOPs or training. So that's something that we have been open about with the national team, been very open that we're looking within our internal systems. And Catherine Sutton and I, with the support of our Deputy Medical Directors then, have looked at the audit recommendations, and we've done a deep dive, and we're currently setting up and in process of a 90-day improvement programme to make sure that we've got those clear processes within the districts, within how the district management teams interface with our acute hospitals, that interface is effective and that we can demonstrate that it's effective, not just that there's a meeting there and a discussion, that we actually can measure and demonstrate what we're doing and how they're being articulated. One of the issues is about clear escalation processes where difference in opinion arise over where patients should continue to receive treatment and who puts people onto the delayed discharge list and how accurate that data is and what that actually means. Because sometimes we do have clinicians who come along to the bedside and will say, well, actually I think you need a care home before the person's actually being assessed. So we need to do some data cleansing and make sure that our processes are right. And one of the issues that we picked up just from examining this more closely was that junior doctors take about half an hour to do a discharge planning letter, but they don't actually do them in flow. They do them when the person is being discharged. So we're trying to build in processes where junior doctors don't feel overwhelmed, but we've actually got discharge letter where people have been in delay and their care is fairly stable. We should be able to have those discharge letters ready and be able to move people very quickly when that opportunity arises. But we do need clear policies and procedures around what we're doing in the hospital, and staff need to clearly understand what their role is. So in the urgent and unscheduled care, one thing that I've been reflecting on is that we may have our assurance report that are written by the work stream leads, but clearly our articulation with the workforce in the operational units hasn't translated and people are not clear. So an opportunity to address that and improve that should help us move people through the system. So there may be, there may be opportunities in terms of agreeing that standard work and people being clearer and all feet to the pump in our 90-day improvement programme. Again, we need to have clear policies and procedures regarding the monitoring review of care at home packages, and we've been doing quite a lot of work to look at how care at home is prescribed, who's actually prescribing it, and how we can make sure that that's reviewed when people actually have the service for a short period of time. There's also another audit undertaken on young adults with complex care packages. So Arlene spoke to some of this earlier, but again, clear policies and procedures need to be in place for the approval of complex care packages in terms of the care that people need going forward. And we need to make sure that that's affordable at the outset and that it's going to meet people's needs, and that we don't end up with top-up costs or agency add-ons and all sorts of things. So again, a deep dive into those processes and looking at standard work, and again looking at the terms of references for the groups who make decisions, so that the governance is much clearer. So all of that improvement work should help us in those areas. And both reports and their improvement plans, I plan to take to the committee, back to committee in September with the details of all of the actions that were taken, so that the committee are fully assured about their response to the internal audit report. Yeah.
Thank you, Pam.
Okay.
Yeah, I think what we'll do is we'll just defer any questions on the audit reports until the next meeting when committee members have the opportunity to read the reports and respond to the improvement plan.
Okay, so some more operational aspects in terms of vaccination service. We've developed a weekly vaccine improvement group. So this is what I mentioned earlier when I talked about 28 work streams. That sounds a lot, but there are specific improvements that we have in terms of addressing some of our vaccine delivery. And as part of that process, senior GPs and the board have agreed a short life working group that will report into the improvement group to compile a general practice options appraisal assessment informed by population uptake and delivery. So from a quality and safety and patient experience perspective, we'll be undertaking that. And a short life working group's been set up and they met on the 4th of July. So we've got a weekly vaccine improvement group. Tim Allison is the executive lead. I'm the operational lead. I chair that meeting, and we've got good project management around that with assurance reporting. So we are more confident around our processes around vaccination, but we still need to demonstrate the improvement. We've only just put in the infrastructure and the plan. The next around feedback from the Joint Monitoring Committee. So the collaborative care home paper and the outcomes for people that we presented at the previous Health and Social Care Committee was very well received by the GMC. So we were pleased to be able to bring something like that to the GMC for discussion. We had the rest of our usual agenda items, but as I mentioned earlier, future agenda setting and the development sessions are being identified for GMC so that we've got a better link and escalation up to GMC of the issues that we need to present to them and in the format that we need to present them. So there is a development session going into the diary. In terms of enhanced services, we've agreed 5 new contracts for enhanced services. We've developed them and they're just in the very final stages of dotting the I's and crossing the T's, but they've been favourable to the Highland LMC. So that's been a positive experience, and there's a further 4 being progressive. We've been working very active in that area, and we've managed to do a lot of work around the contracts and the costing and the delivery models, and that's been really positively reflected by LMC and by NHS Highland. The joint strategic plan I've already spoken about, and then finally just to mention the National Care Service Bill. So the bill's at stage 2 and progressing through the Scottish Parliament. So they have published a list of amendments, and you know, we've had some ministerial correspondence, and we are anticipating that new arrangements will not come into force for at least another 18 to 24 months. There's been a briefing provided to NHS Highland and the Highland Council, and we'll take that forward in development sessions in much more detail, and it's too big a subject to to respond to today. But as I've proposed, we may want to consider a more detailed paper or hold that in a development session once that's been to the NHS board and we're clearer about as an organisation about how we'll respond. Okay, thank you. Now I've got Elaine's cough. It must have come over the airway.
Thank you, Pam. Thank you, Pam. A lot in there. Maybe I'll just throw it open for quick questions. Anne.
So just on vaccinations, Jerry, and given the time where we are, so just a couple of things, Pam. So what do you think the implications are of the peer review and the decision to form the short life working group to do to do the options appraisal in terms of the timescales for a new delivery model being in place, and whether we're still looking at having something in place before the winter vaccination programmes, or whether that'll have to shift. So that was my first question. And second one is really one of the things that struck me in thinking about this, and we've got a much more detailed paper on all of this for the Clinical Governance Committee tomorrow as well. It strikes me that the context of delivery of vaccinations has changed quite a lot since the since the change to the contract and the requirement that was put on us pre-pandemic to introduce a new delivery model for vaccinations. And I just wondered whether you know how the current situation compares in terms of the number of vaccinations that require to be delivered now as before, because that strikes me as one of the things that we possibly have to be quite thoughtful about and presumably will be taken into account in the options appraisal.
Absolutely, we're delivering significantly more vaccinations across all of the programmes, particularly across the adult programmes, than we were prior to vaccination transformation. So I can bring back that figure to you, Anne, because we do have that figure. In terms of the vaccination model and the redesign and the alignment with the districts, any variation to deliver vaccinations by general practice will still be subject to Scottish Government approval. So that is something that we've got no control over the timeline. So there is a short life working group looking at that as part of the vaccination improvement process. What I would say is when we articulated the alignment into the districts, we weren't at that time as a board considering the variation process because we had thought that very, very lengthy when it had been undertaken in Argyll and Bute. So perhaps the appetite wasn't there. However, we have revisited that. We have met with Scottish Government and with Scottish GP committee representatives, etc. And we understand the process, and we are looking at alignment in districts as well as with general practice, and we'll take that forward within the policy framework. So it'll take us slightly longer, I think, than the autumn timeline proposed, but one thing I would say is where we did have capacity issues and where there were going to be delays for some delivery, we were able to align quickly with one GP practice to deliver vaccinations on our behalf. So I'm not wanting to get into too much of the detail in the discussion at the moment, but I'd be happy to provide a more detailed paper going forward.
Okay, so, well, I think given what you're saying about the timescales probably being impacted, I suppose my reflection on that is that the improvement work to improve the existing delivery model is as important
Yes,
as
absolutely.
any consideration of flexibility or different models, you know, being what we're looking to going forward. So I guess it's that's my reflection and a request in terms of, you know, future reports to give assurance that progress is being made, you know, that it addresses the improvements that we need to make to the existing system as much as it does look at future or different options. Thanks.
Absolutely.
Thank you, Anne. Neil.
Very mindful of time. Just to second Anne's points there regarding vaccination, and the whole PKIP process since 2016 when we started negotiation, 2018 when it came in, the new contract. I think the whole environment has evolved, to put it mildly. What was seen before as immovable, defined sort of standards or criteria, or what government wanted has changed, and so hopefully we'll see some flexibility there, particularly with things like vaccine delivery. Yeah, we've all seen the numbers. They came round all the practices, I think. We looked at those, we were somewhat shocked, and you can take a step back and think, well, a previous model got better results for less cost. But we are where we are, so yes, you've got to keep working with what we've got, do the options appraisals, hopefully it'll come through quickly. I would just say from practices' points of view, they need to know that things are going to be sustainable. Yeah. Because it's we run as, the vast majority of GMS run as effectively small business models. We have to employ people. And so those GMS practices need to know that they can continue to employ people. We don't do 0 hours contracts. So yeah, and that also counts for enhanced services. We're really grateful. I just wanted to make a comment. We're really grateful that that's progressed. Colleagues have said to me they're grateful, and that's really good to see, because again, it's about sustainability. And and I'm just looking at my printed out copy of the primary care driver diagram from the transformation process, and there it is, sustainability in primary care services. And that's what we need. We need to know that we're on sound financial footings so that we can employ and provide, and we can, yeah, we've said it before, we'll say it again, move care from the centre out to the communities.
Yes.
So yeah, so thanks very much.
That's really helpful feedback, and I have absolutely wanted to improve our engagement with primary care and our partnership working in terms of delivering not just a joint strategic plan, but vaccinations and delivering on our renewed enhanced services as well. So it's moving along positively. So that's been a good experience. So good to have your feedback. Thank you.
Thank you for that, Neil. I think it goes to, I think your comments regarding that sustainability are absolutely crucial, and I think it just goes to the wider board role and actually helping to provide that stability and sustainability to the market as well, and moving away as far as possible from this short-termism and actually providing that support. So thank you very much indeed for that. Pam, thank you very much for that very comprehensive and detailed report today. We've been asked to consider the report, which we have certainly done, and identify any matters that require further assurance and or escalation to the board. I'm not so sure about escalation, but I think certainly what I would be feeding back to the board relate to the vaccinations and where we are. But I'll agree with yourself in terms of what the wordings are, because I'm aware that there's a great many people involved in those discussions. Okay, thank you very much indeed. We have no committee function administration business to take forward. Any other competent business that anyone wishes to raise? I've not been advised of any. Nope, I don't see any hands, and I'm not going to give the opportunity for any to go up. Date and time of next meeting, 4th of September at 1 o'clock. But if I could just remind everyone again, we've got our development session in a couple of weeks, and I'll ask Stephen maybe just to send a reminder round to everyone about that, and I'll speak to Pam, and we'll get some papers or thoughts so people can come prepared in terms of. But I think based on today, I think you know what we're going to be talking about in terms of strategy. So thank you very much, everyone, for your perseverance today. I know it was a long meeting, but I think we've covered an awful lot of ground today, and thank you very much for your forbearance, and I wish you well this evening. Thank you very much indeed. Bye-bye.
Yeah,
Thank
thanks,
you.
Jenny.
Bye.
Bye-bye. Bye-bye.
Bye.